Dr. Allan Pamba. Dr. Pamba is the CEO of the Nairobi Hospital. Allan, good morning.
Good morning, Latif. Good morning, Joe.
Good morning, Allan.
Good to speak to
How
you
are
again,
you?
Allan. And well, we know that since the last time we spoke, we were talking about how hospitals are basically seeing the impact of COVID-19 as businesses.
That's right. It's quite interesting how, and I think Joe described it very well. We did our best to make our hospital safe, but we also scared everyone out to the hospital, and people did what we asked them to do and stayed away. Even when we were ready for them to come back,
Yep.
they were still fearful. And I think now the government has, given a very blanket welcome back to your hospital statement.
Yeah.
And we're beginning to see a trickle back in. It's interesting how COVID has panned in Kenya. We had very big numbers initially that were predicted.
Yep.
I think we've done all the right things. The numbers have stayed manageable. And there's a whole debate around, did we overdo it, or are the numbers manageable because we did the right things?
Yep.
But so far, so good.
Now, the DG for health says people can come back, but then you've got to observe certain measures.
Right.
Just take us through those critical measures that you have been outlined by the government.
I think the main thing, Latif, is to ensure that the public remains safe even as they get their regular care coming back into hospitals. And indeed, we've had quite a bit of time to ensure that. We put up, if I talk about the Nairobi Hospital, we have put up temperature and history screening points as you come into the hospital. So whereas before you come straight into A&E and then somebody will see you, triage you, and put you in the right place, you go through this pre-screening that happens on the parking lot of the hospital. We have a tent we've set up there.
Okay.
They take your temperature, they take your history, and if there's anything suggestive, we have another tent next to this one where you can get your COVID testing done. And then, depending on how your results pan out, you will be channeled to one or the other parts of the hospital. So the hospital is essentially divided into two. We have an isolated facility dedicated to COVID, which you will never see unless you have COVID, and I hope you never see it. And then we have the rest of the hospital, which functions essentially normally. And you will not even know where the COVID facility is when you come. You will see people in the corridors following the other
Allan,
protocols.
you're making this sound like it's somewhere in a bunker.
Well,
It's a panic room for COVID in Nairobi Hospital.
no, Latif, it's important that we make sure that we follow infection prevention control measures strictly with this. In other countries, they've separated their hospitals into, you're going to be COVID hospitals and treat nothing else, and you're going to be regular hospitals.
Yeah.
Yep.
We haven't done that in Kenya. We have to do it at facility level. And when you follow your IPC protocols strictly, it means the area where you're managing COVID patients, no one can stray into it by mistake.
Okay.
There are very clear protocols on people's movement, so nobody strays, whether it's a health worker or a member of the public.
Okay.
And that's what we've done at the Nairobi Hospital.
So does this mean that some people who are working in this COVID facility, the healthcare workers who are working in these COVID facilities are working exclusively in this COVID facility?
Correct. So, and when they come in, they will be dressed like all the other health workers until they get into that zone. And when they get into that zone, they have an area where they will don their PPEs and then cross into, what is essentially the COVID area. So the wards where these patients are. And then they'll work a couple of hours. And because it's very hard to be on PPEs the whole time, then they come out of PPEs and they have their resting area within that space.
Okay.
They get their meals within that space and they turn shift around that space. Yeah, and then eventually they'll go home like everybody else,
Right.
And that's their workstation.
Okay. So then do you have a crossover of medical staff between the COVID area and the other areas?
The medical staff can cross over in common areas, but remember when they get into the COVID area, they're fully protected because they're donning their PPEs.
Okay.
And then when they come out
I don't mean just crossover taking a walk, but actually to work.
Right. No.
No, they don't.
No.
So a nurse who's working in the COVID area will not come to the general area.
No.
To work.
And if they have to come to the general area to work, there's a whole testing process that follows before they cross over.
Okay.
Yeah.
Do you think that even without the government directive, Allan, that you would have been able to do both? That you would have been able to continue with business as usual for surgeries and the like in the hospital while still having a fully functional running COVID area?
Oh yeah,
and not just you, but not just you as the Nairobi Hospital, but other facilities as well.
We can do, but it depends on your team of medical expertise. So at the Nairobi Hospital, we're lucky we have an excellent team of infectious disease specialists, right across the spectrum from doctors to nurses, etc. These are folks who understand infectious disease and the protocols that are required to manage the same. So they're the ones who come to the fore when you have a condition like this, and they decide and they define the protocols for us as a hospital. As it were, a lot of the things that they came up with mirrored what the government eventually came up with, and hospitals built their protocols over time, or so the government either the one in tandem with the government or a little bit ahead. So we had an excellent team that defined this very early on, and we were ready, I think, for months, for many weeks now, to run these essentially two hospitals in one. But patients coming to COVID did come, and we've managed quite a number of cases, and we continue to do so. General patients coming to the other part of the hospital were slow to come to the point you already made, though. And now they're coming. Now they're getting confident. Now they're beginning to come again.
But this is, Allan, this is only at the Nairobi Hospital, main hospital.
That's right. If you go to a satellite clinics, however, you will also see similar protocols in terms of temperature history screening as you come in. And then a separation happens very, very quickly if you have suggestive symptoms for COVID. And within our satellite clinics, we've built a very strong referral system into our hospital, specifically for COVID. We have a dedicated ambulance with a dedicated team that quickly come and pick up a patient who may need to be brought to the hospital because they have symptoms suggestive of COVID.
Does this regulation not put up some strain in terms of operations and challenges? For example, when the government says you should have a dedicated ambulance that deals with COVID.
Latif, you're right. This is it's not cheap, right? It's a huge cost. Not every hospital will be able to do this.
Yeah.
Our ambulance is busy, not just picking patients from our clinics, but also from other hospitals and other centers. So that co-sharing is important to make sure that resources that don't have, or institutions that don't have that level of resourcing, leverage what is essentially a dedicated ambulance that probably has 2 trips for us in a day, or one.
So you'll be able now to share this particular COVID ambulance with other facilities.
Correct.
Okay, now let's talk about, looking at, this is just a private hospital that's able to come up with these protocols and roll them out. Let's look at the other smaller private hospitals as well. Do you see them being able to come up with all these measures? Are we talking about the ones? We're talking about the ones that are, talking about the other smaller hospitals that even have had to fire their staff or reduce their staff or even tell their staff to go on unpaid leave because of reduced operations, their capacity, where they operate, their spacing. Are they going to be able to do to meet these protocols?
It's an excellent question, Latif. It's difficult. It's very difficult for small hospitals. It's difficult for all businesses, but that includes hospitals. COVID has changed, our world the way we know it. It started off with other businesses laying off staff, etc. Now you're seeing hospitals being impacted in that way. And some of the small ones got caught up with what happened to protect the public and keep the public safe coming into hospital. All the measures that were pronounced by governments and some hospitals independently like us, advising the public, you can't come into hospital to visit your patients anymore. Our opening hours are now restricted. We've closed down the satellite. All the things that we did that scared people off.
Yeah.
But were required to make the hospital a safe space for the regular patients. Some small hospitals are having to pay a price for that. And it's very unfortunate. The revenue streams that went really down in the months when patients didn't come resulted in what you've seen, which is pay cuts and staff being sent home. Some hospitals can recover from that, others won't be able to recover from that. Specifically to your question, Latif, will the small hospitals be able to do this separation in managing COVID? It depends. You've got to box very smart as a small hospital to do this.
Yeah.
And where you can't, some hospitals just make the decision, look, we can't have a facility to manage COVID. If you've got a case, take it to the Nairobi Hospital, and they will build a referral linkage, so that they just focus on regular patients.
Which is where now that other question comes in. Are there conversations like this that are happening? Maybe through the umbrella, the Association of Private Hospitals and such? Because I am seeing a case where patients take themselves to hospital. You go there, but because of at the initial screening, the healthcare worker suspects that there could be a case of COVID, they turn you away and they don't even tell you, this is where we want to send you. We want to refer you to this other facility. They basically tell you, where we're going to COVID, don't come in here.
Well, that would be unfortunate, Latia. I hope it's not happening in that manner. There is a certain level of decency that we must display as healthcare providers in giving patients the right set of information. People just want to know the truth, It's a scary thing to be told, we suspect you have COVID, sorry, you can't come here.
Yep.
Make the story complete by saying, look, we suspect you have it, you may or you may not. Here are 2 or 3 other facilities that are doing this better than us. We're going to call them, they'll come and pick you up, and they've got solid protocols that take care of you. I'm sure these conversations are happening. I have to be honest, I have not been involved in any probably at my level. I've got my doctors probably doing this.
Okay.
But for small hospitals, I'm very sure, they're trying to see how they can build these referral linkages. Because even having an isolation ward where you're managing purely COVID is a big resource. I've got 37 beds dedicated to COVID. Any one time I've got 12 patients on average. I've got the rest of the beds empty. But in the event that there is a surge and we have many more patients, I'm ready for that. Not every hospital has the luxury to do that.
Allan, there was a lot of convoluted messaging that came from the beginning of all of this, just that we've talked about now, and then could also give rise to the decisions that a lot of people made not to come to hospital now. In this instance, whereby it's being rolled out slowly, how then would healthcare facilities, hospitals, be able to unravel this messaging and now put through the messaging that you can come back and it is safe? Because people's decisions were made, whether the messaging that came out was solid or not, it was made on that. How are we going to change that in this time and let people know that they can come back without any doubt?
It's really a very good question, there. I think it's a concern on the top of many doctors who want to see the regular patients and not see them when they have deteriorated too much. And also for us as hospitals who have facilities that are ready to take care of the patients. And we know we've got Mr. So-and-so who's an hypertensive but hasn't been here for 8 weeks. Mr. So-and-so who's a diabetic but hasn't had, his insulin for a long time. And you begin to wonder, are they safe? Are they okay? So we are all concerned and we'd like them to be able to come back. Now, word of mouth is very powerful. So the few patients who come and see the protocols in operation, so you come to the Nairobi Hospital, you get your temperature and history screen, you walk the corridors, you see everyone wearing a face mask, people social distancing. You go to the pharmacy, you can see the spacing in the waiting area is different than what you saw before. So you navigate all of that and you come out and you think, actually, I'm probably safe coming to this space.
Yeah.
And then you tell your family and friends.
Yep.
And they're going to trust you probably more than they'll trust me, or trust Dr. Moses' government in any pronouncements we make in the press. So word of mouth is powerful, and I think that will help us. The other one is the doctors, the actual doctors who see the patients. Patients trust the doctors a lot. If your doctor calls you and say, well, now you can come in and I'll do that elective surgery, or I'll see you in my clinic at the Nairobi Hospital, the patient will come because they trust their doctor. A lot more than if I said it as the chief executive of the hospital. So that's another way in which I think we will get, and the doctors are coming back. When this happened, not only did patients not come to the hospital, but many consultants closed their clinics because they wanted to be safe as well. Thankfully, they've all now reopened their clinics, and they will be our biggest critics as management of hospitals. They'll walk the corridors and they'll point out if we have any gaps. And the fact that all my consultants are back running their clinics gives me a lot of confidence that our protocols are good and that our patients are safe coming back into our compound.
Dr. Allan, let's now talk about that. We are reopening. So doctors are back. The president is saying we need to start thinking of how best to reopen, and also borrowing from examples of other countries. Do you think reopening would cause us to see a spike in numbers, or even second, put us back into danger?
So what am I observing, Latif? So here's my view on that. When we started dealing with COVID, our government took very drastic measures. If you compare us to Tanzania and to some extent even Uganda, we were quick. We were quick in shutting down air flights into the country, shutting down schools, colleges, and very quickly moving it to everyone wearing a mask. The numbers that we predicted were scary. And quite honestly, myself, as a CEO of a hospital, I was scared. I mean, I did a couple of interviews early on in the pandemic where I talked a lot about, look, this battle is on two fronts. At the moment, it's on the social front. We need to win it there. If we lose it there, it comes to the hospitals. And, turning the hospital into a COVID battlefield, the way we've seen in New York, Italy, Spain, etc., Kenya wasn't ready for that. We just didn't have the capacity to do those large numbers. So I think some of the things that the government did, the numbers that were predicted and the measures that were implemented, probably flattened the curve. Now, nobody talked about that. It's a difficult thing to prove. And what you're seeing now is people beginning to think, well, this COVID thing isn't so bad. I need to get back to my daily hustle.
We can live with it.
And hopefully, I can navigate all spaces they used to, navigate without much fear. And so, and the government is sending messages also in that direction that, look, we're going to start reopening the economy. Hopefully, they calibrate the reopening gently so that it's not a sudden, everything is free for all, schools are open, everything is open. And we keep some of those good behaviors that we've now developed, social distancing, wearing masks, not shaking hands, etc. If we open it in a calibrated manner, I think hospitals have had quite a lot of time to prepare to deal with this. It's not perfect, but we're in a much better place than where we were at the beginning of this.
Okay.
The numbers that have been coming are more manageable, and they probably might be a small spike, but probably manageable.
Okay. So if looking at a spike, Allan, and saying that, all right, we are prepared, as facilities to take in, if we do, because the fear before was that the system was not going to be able to handle it if we had several cases of the critically ill. If those cases do increase, are we comfortable or confident that we would be able to handle more critical cases? And I'm not talking about expertise, Allan. I'm just talking about space at this point. Space and facilities.
So many hospitals have, the bigger ones at least, have built space to take care of COVID. and have also had staff to double with COVID. I call it double because our numbers have been manageable, right? So we haven't had a shock into the system where staff are, dealing with overwhelming numbers. And it was interesting that at the beginning, even staff were scared. The confidence to walk into an isolation ward was weak. Now I see my staff very confident. They come, they don the PPEs, they get in there, they get out, very confidently. And that's what I'm talking about, that it makes me feel if we had a spike, I wouldn't have people standing at the corner thinking, I'm not going into that room. I'm not dealing with a patient, We've got people who have done it already, and they're a little bit more confident, and they've had a lot of success, and many of those patients have recovered. Now, if we do have a big spike, we will be overwhelmed. That I will tell you for a fact, because the number of ventilators we have in the country has not massively increased. For example, the COVID essential item supply chain has not completely corrected. We're still buying PPEs at crazy prices. It's beginning to correct, but we've not secured those supply chains yet. And that's why I caveated the reopening of the economy to something that needs to be done cautiously so that the numbers are manageable as they trickle into the hospital.
All right. I guess still looking at how things will continue to unfold as we see how things progress. Dr. Allan Pamba, CEO of the Nairobi Hospital, thanks for talking to us this morning.